So you tore your ACL, you're waiting for surgery, and now you're thinking, what graft should I go with? If that's you, kudos. Most people walk into surgery blind. You're doing your homework, and that matters. Here's the truth. There's no perfect graft, but there are better choices for specific people, and many don't give this much consideration until the surgery is already complete. Each graft has its specific pros, cons, and unique rehab implications that are important to understand. The best choice will depend on a variety of factors and should always be a collaborative decision between the patient and the surgeon. In this video, I'm breaking down every graft option, what the research says, what to expect during rehab, and how to make a decision that actually fits your goals. Let's dive in. Let's start with the allograft. This is when the graft is taken from a cadaver rather than your own tissue. One of the biggest advantages to this is that there is no donor site, meaning there are no secondary areas of your body that require additional healing. But here's the trade-off. In younger, active individuals, allografts consistently show higher failure rates, particularly for those in their early 20s and younger. Some studies report a 3 to even 4-fold increase in re-tear risk for this population. Part of the reason could be due to a slower revascularization and recellularization process, meaning it takes longer for it to develop comparable blood supply and strength compared to autografts. Graft failure seems to be age and activity dependent, however. For less active individuals in their 40s and older, we start to see failure rates level out compared to other graft types. You may also hear about disease transmission and the risk for your body rejecting the graft. However, this is becoming much less of an issue with improved sterilization techniques. And finally, for people who need surgery through multi-ligament injuries, allografts are commonly used. So if you're in your mid to late 30s or older and don't plan on getting back to high-demand sports or activities, an allograft could be an appropriate choice. However, there is one critical component that you should understand. For those of you who fall into this age and activity level bucket, there's increasing scientific evidence showing similar long-term outcomes between those who get ACL surgery and those who choose the non-surgical route when they get high-quality rehab. So before rushing into an allograft, it's often worth trialing at least 3 months of high-quality rehab first. Let's shift gears to autografts, which is when the surgeon will use tissue from one part of your body to reconstruct your ACL. The Bone-Patellar Tendon-Bone autograft is considered by many to be the gold standard for younger, active individuals looking to get back into cutting and pivoting sports. Unlike soft tissue exclusive grafts, this surgical technique incorporates what we call bony fixation. When harvesting this graft, a surgeon will remove the middle third of your patellar tendon along with bone plugs on either end of the tendon, coming from your patella at the top and the tibia at the bottom. When implanted into the knee, these bone plugs heal within the bony graft tunnels, making it strong and reliable. Historically, there have been many published studies showing lower graft failure rates when comparing the patellar tendon autograft to hamstring tendon autografts, and more recently, quad tendon autografts. But here's where things get interesting. Newer meta-analyses and systematic reviews, which are studies that pool together the findings of many other studies, have shown that failure rates between autografts are actually more similar than what many are led to believe. When the data is pooled together, the differences appear to be small and even arguably insignificant. But each study has its limitations, which are important to consider. Individual factors do matter and should be considered when selecting an appropriate graft. So a lot of people automatically think that the patellar tendon graft is the best, but it's not always so clear. It can be a great choice for some and not as great for others. Remember, each one has their unique pros and cons. So what are the drawbacks? First off, the knee extensor mechanism is disrupted as they are taking the grafts from a major tendon in front of your knee. This has been shown to produce higher rates of anterior knee pain, increased occurrence of kneeling pain, increased risk of patellar fracture and tendinopathy, and greater quadriceps muscle weakness. In addition, Particular consideration should be used for younger patients who are skeletally immature, as this surgical technique may compromise open growth plates and result in growth arrest. So if you're a skeletally mature young adult or even in your mid-30s and plan to return to a high level of physical activity, especially cutting, pivoting, and jumping sports, this can be a solid graft choice. Next up is the hamstring tendon autograft. This one gets a lot of mixed messaging, so let's clear it up. This graft is taken from the semitendinosus and or gracilis tendons, which are located on the inner portion of the knee. Surgically, these can yield variable sizes and constructs. A big positive for this graft choice is that it does not interfere with the extensor mechanism of the knee. So pain in the front of the knee, kneeling pain, and quad weakness are less of an issue. In fact, one study concluded that individuals with patellar tendon grafts took 1.5 months longer to meet running criteria and 4 months longer to meet return to sport criteria, although the outcomes were similar by the 1-year post-op mark. This is also a popular choice for the skeletally immature individuals with open growth plates, as there is less likelihood of causing growth arrest. But there are important considerations. In contrast to the patellar tendon graft, there are no bone plugs, so there is what we call soft tissue healing within the bony tunnels, which may require longer healing and less overall fixation strength. One of the biggest potential drawbacks is graft failure rates. Research suggests higher graft failure rates, especially within certain groups, when compared to their counterparts. For example, this study demonstrated that females between the ages of 15 and 20 years old showed fewer graft ruptures with the patellar tendon graft compared to those who received a hamstring graft. However, as previously stated, other studies reveal that the differences in failure rates may not be as significant as once thought. Since this graft is taken from your hamstring, knee flexor weakness is common and can persist for up to 2 years or even longer after surgery if not addressed. And those people with a history of hamstring strains and those who need to sprint a lot should take this into consideration. So who is this best for? Skeletally immature individuals, those who kneel often, and those who are returning to level 2 sports, which involve less pivoting than level 1 sports. The new kid on the block is the quadriceps tendon graft, and it has gained popularity fast. Surgically, they are strong and reliably thicker grafts that have shown to have some promising outcomes. A 2019 paper demonstrated less anterior knee pain, less kneeling pain, and comparable functional outcomes to the patellar tendon graft without the persistent knee flexor weakness seen with the hamstring graft. But here's the catch. The amount of long-term research is lacking. More recently, research has shown that the knee extensor strength significantly lags behind the other two autograft options at 3, 6, and 9 months post-surgery. Being that quadriceps strength is one of the strongest predictors of functional outcomes and re-injury risk after ACL surgery, this is an extremely important consideration for quad tendon grafts. Quad tendon grafts also carry an elevated risk of post-surgical knee stiffness due to larger graft size, as well as increased quads inhibition, which can make it even more difficult to restore full extension range of motion in a timely manner. So who may be best suited for this graft? Active people in their mid-30s or younger, those returning to high-demand sports or activities, and those who need to kneel during sport or work. Let's talk about the even newer kid on the block, the bridge-enhanced ACL restoration implant, aka the Baer implant. This is not a graft. It's an implant used to connect the two torn ends of your ACL to facilitate your body's natural healing process. Your surgeon injects your own blood into the implant to help stimulate this healing. Similar to allografts, there is no donor site morbidity since they are not harvesting your own tissue to make a graft. Less overall healing is a strong positive. But due to its recency, there's not strong long-term data on the Baer implant as of yet. Early studies do show positive results that are comparable to an ACL reconstruction. However, it's uncertain if the Baer will outperform them in the long term. It is important to note that the Baer implant requires a specific ACL tear pattern. And since it's a newer technique, there are not as many surgeons that perform this procedure. Important distinction, an ACL repair is not the same as an ACL reconstruction. People use these terms interchangeably, but it's not correct. A repair is far less common procedure that aims to preserve the original ACL by suturing the torn ligament back together. A reconstruction replaces the original ACL entirely with a graft. Since they are suturing your body's native ACL, there is no donor site morbidity, and research has shown quicker recovery times compared to reconstructions. Primary repairs, however, require a specific tear pattern and tissue quality, and they are not commonly performed. Long-term data is limited. Let's touch on two additional procedures that are sometimes performed alongside an ACL reconstruction: a lateral extraarticular tenodesis, or LET for short, and an anterior lateral ligament reconstruction, or ALL. These supplementary procedures both add extra rotational stability to the knee, which has been shown to reduce re-injury risk, especially for athletes returning to cutting and pivoting sports. But again, these are additional procedures which require more healing. So if you're stuck choosing, here's the simplest way to think about it. Mid-30s and younger with a return to cutting sports, lean autograft. Mid-30s and older and less active, allograft becomes more reasonable, but high-quality rehab should be strongly considered first. You need to kneel a lot? Probably steer away from the patellar tendon graft. Hamstring strain injury history and a high demand for sprinting? Be cautious with a hamstring graft. Concerned about quadricep strength recovery? Be mindful of the quad tendon graft. And if you want the newest option, the bare implant may be an option for you if you fit the criteria. Surgical choices are incredibly important, but here's something almost nobody tells you about before surgery. A perfect surgery means nothing without high quality rehab. I've worked with numerous people months or years out from surgery who still struggle, not because their surgery failed, but because their rehab failed them. And the statistics don't lie. Most people don't achieve the clinical criteria needed to safely return to their active lifestyle, which is a major contributor to re-injury risk and long-term outcomes. This is why choosing your physical therapist is just as important as choosing your surgeon and deserves equal consideration. ACL rehab is complex and truly requires a physical therapist who is up to date and understands the research, knows how to progress and prepare someone to return to their desired goals, understands tissue healing, and knows how to properly test you throughout the process. Proper rehab will have a major impact on reducing re-injury rate, your long-term joint health, functional outcomes, and ability to return to activities that you love. So choose wisely. If this video helped, hit that like button, drop a comment, and subscribe. It goes a long way. And if you're stuck at any point in your recovery and want expert guidance, or maybe you want to put yourself in the best position possible to crush your rehab, click the link in the description to book your free call with me. We'll figure out exactly what's holding you back, and I'll show you how to develop a game plan and recovery plan that actually gets you back to the activities that you love.